On a traditional assembly line, pulling the red cord stops the process to fix a dangerous, defective part. Modern doctors are trained to act as this red cord. Their ethical guidelines place a mandatory duty on them to report unsafe clinical practices. But in a massive healthcare bureaucracy, pulling that cord rarely halts the machine. It often opens a trap door beneath the feet of the person who pulled it. Dr. Kadiyali Srivatsa was a veteran critical care physician who followed that mandate. His decades of experience led him directly onto that trapdoor. Systems designed to safeguard patients possess a powerful secondary directive, the protection of their own architecture against any perceived internal threat. In 2006, the NHS implemented a policy shift that moved patient triage into high-volume, nurse-led clinics to maximize efficiency. This model relied on cookbook medicine. Staff without extensive schooling diagnosed complex pathologies by strictly following rigid, pre-printed flowcharts. This reliance created dangerous blind spots. In one instance, a systemic rash was misdiagnosed as simple eczema because the flowchart only offered a narrow yes-no pathway. Following that protocol, the clinic prescribed immunosuppressive steroids. When given to an infant with a systemic condition, this treatment caused a rapid, predictable deterioration. Aviation checklists work because a Boeing 737 is a standardized machine. Human biology, however, is infinitely variable, presenting nuances that static flowcharts cannot account for. Algorithmic triage treats every patient as a statistical average. This removes the specialized clinical intuition required to identify and save the outliers. Dr. Srivatsa began documenting these failures. He gathered evidence of delayed treatments and wrong procedures, presenting them through the official channels of his local primary care trust. The sheer volume of evidence was undeniable. This file list catalogs years of recorded clinical errors and safety warnings submitted between 2003 and 2007. He believed that by presenting this data, the regulatory bodies would evaluate the risk to the public and correct the clinic's protocols. The administration viewed the situation differently. They prioritized the clinic's economic stability, seeing the doctor who identified the error as the primary problem. This creates a paradox. Obeying the duty to report harm activates a mechanism designed to eliminate the reporter, rather than the risk. The primary care trust immediately breached Dr. Srivatsa's confidentiality, betraying the trust required for whistleblowing. His safety reports were sent directly to the managers he had implicated, giving them the names of their accuser. Those managers orchestrated a coordinated counterstrike. Staff filed fabricated complaints against Srivatsa, alleging behavioral issues to distract from their own clinical errors. The resulting legal battle is recorded here. The filing outlines a clear history of constructive dismissal and professional detriment following his protected disclosures. This illustrates regulatory capture. Management uses mandatory investigation protocols as a shield, freezing the whistleblower in place with administrative proceedings. Regulatory bodies are legally required to investigate any formal complaint. This allows bad actors to hijack the system to bury the original malpractice report. Compliance mechanisms are easily weaponized, transforming the search for truth into a tool for silencing critics and protecting the institution. Based on these unsubstantiated claims, the General Medical Council launched a disciplinary inquiry that lasted 4 years. This was a battle between an isolated individual and the state. Srivatsa had to fight against limitless, taxpayer-funded lawyers from his own life savings. The structure of these tribunals is inherently flawed. They use laypeople and generalists to evaluate the highly technical decisions of a critical care expert. Srivatsa challenged the tribunal's ability to judge his work, arguing that asking a layman to evaluate decades of medical intuition is as illogical as asking a plumber to assess the integrity of a bridge. Disciplinary proceedings successfully divert public attention. The focus shifts to the troublesome doctor, while the unsafe practices at the clinic continue without scrutiny. The investigatory process functions as a risk management protocol for the institution. Its primary purpose is to contain the whistleblower, rather than correcting the clinical flaws he identified. When the administrative pressure didn't work, the system moved to financial starvation, actively blocking Srivatsa's ability to earn a living. His name was removed from the national performers list. The health authority dismissed this career erasure as a computer error. He was even blocked from working as a temporary substitute in other towns, a sequence of events the documents describe as the Oxford trap. Bankrupted and isolated, he faced a complete professional erasure, a devastation that few doctors survive without psychological collapse. During this period of total professional isolation, Srivatsa looked back at his lineage, tracing his family's 600-year connection to the temple of the divine physician, Karthikeya. By unlearning his institutional habits, he found a deeper moral code. He began to view his duty through the lens of dharma, the requirement to uphold truth regardless of the personal cost. This systemic destruction stripped away his institutional identity. It was only after losing his career that he could build something that bypassed the machine entirely. The cookbook medicine Dr. Srivatsa tried to stop has consequences that extend far beyond a single clinic in Woking. This microscopic cluster represents the post-antibiotic era. We are facing a future where routine infections become life-threatening because drugs are losing their efficacy. Defensive medicine fuels this crisis. Doctors operating under intense time and legal pressures often overprescribe broad-spectrum antibiotics simply to appease anxious patients. Algorithm-bound clinics accelerate this. Static flowcharts lack the nuance to safely differentiate between a viral illness and a complex bacterial pathology that actually requires medication. By 2050, the global projection is 10 million deaths annually from untreatable superbugs. The rigid adherence to these economic protocols has a cost far higher than a single doctor's career. It is systematically eroding the biological efficacy of our most vital medicine. Srivatsa realized that if the system prioritizes liability over truth, patients can no longer rely on institutions alone for their protection. He distilled 4 decades of clinical experience and the hard lessons of his institutional struggle into a new medium. This led to the creation of Dr. Maya AI and the Prema Kiosk Network, tools designed to operate independently of the bodies that dismissed his warnings. While traditional hospitals are built on top-down, defensive hierarchies, this AI ecosystem is a decentralized web designed to empower individual users. The technology educates the public to understand their own symptoms and conquer their medical fears without a blind reliance on a clinic's flowchart. Reducing this dependency and the resulting fear-driven overconsumption of drugs is a critical defense against the post-antibiotic threat. Srivatsa's experience demonstrates that when systems fail, localized, decentralized innovation provides the necessary mechanism for individuals to protect themselves.